This is an introductory talk on head injury assessment in the emergency department for SHOs. The talk lasts for about 10 minutes and aims to cover the key topics of head injury assessment. These include the initial clinical assessment, clinical features of head injury, the criteria for requesting CT imaging of the head, and the criteria for requesting further imaging of the cervical spine. We're going to go through the special considerations, including the anticoagulated, intoxicated or elderly patient. We're going to talk about discharge criteria and discharge advice. And finally, patients who present with post-head injury symptoms. Patients who present with a head injury should, like most other patients, have a thorough history and physical exam. The examination should include looking for evidence of head trauma, which mainly involves looking at the scalp and the face for evidence of direct trauma. In addition to this, you should look for evidence of a basal skull fracture, which includes pandarise, CSF oto or rhinorrhea, hemotympanium, and battle sign, which is bruising of the mastoid process. You should assess the cervical spine in any patient who has an injury above the clavicles, which includes any head injured patient. The Canadian and Nexus C-spine rules are useful to aid you in this process, and we're going to discuss more about this shortly. In all patients, a comprehensive neurological exam, including the pupils, mental state, Glasgow Coma Score, cranial nerves, and peripheral nervous system exam is required and should be comprehensively documented. This slide lists the clinical features which can be seen in a patient who has sustained a head injury. It is important to document if any of these features are present. However, it's just as important to document the negative findings in the head injured patient, which include the conscious level, absence of amnesia, absence of focal neurological deficit, absence of vomiting, absence of loss of consciousness, and absence of the signs of the basal skull fracture or depressed skull fracture. Unfortunately, on occasion the emergency department doctor will find themselves in the coroner's court needing to justify to the coroner why they have decided not to request CT imaging of a patient's brain. It is therefore vital that you record enough clinical information to allow you to make this justification. NICE have issued head injury guidance to assist us in making a decision as to whether a head injured patient requires a CT scan of their brain or not. This guidance is essentially summarised in this algorithm. To get into the algorithm, you have to be an adult who has sustained a head injury in the emergency department, and then you have to look for any of these positive findings, either a GCS of less than 13 on initial assessment, or a GCS of less than 15 at 2 hours after the injury, a suspected open or depressed skull fracture, any sign of basal skull fracture, a post-traumatic seizure, a focal neurological deficit, or more than one episode of vomiting since the head injury. If the patient has any of those clinical features, then they should have an immediate CT scan, which should occur within 1 hour, and a written report made available within an hour of the CT taking place. If the patient doesn't have any of those clinical features, then there was a couple of additional questions that you need to ask. Firstly, is the patient anticoagulated? And if they are likely to need a CT scan of their brain. And I'm going to just hold off discussing that further because we're going to come on to some more detailed guidance regarding this in a minute. If they're not anticoagulated, then the next question to ask is, has there been a loss of consciousness since the head injury? If the answer to this question is no, then they don't need any further imaging. If the answer to that question is yes, then we need to ask, are any of these additional factors present? Is the patient over 65 years of age? Is there a history of bleeding or clotting disorder? Is there a dangerous mechanism of injury? Or is there more than 30 minutes of retrograde amnesia of events before the head injury. If in those circumstances, if the patient has any of those features, then they should have a CT scan within 8 hours of the head injury. In all cases where evidence of an intracranial injury is demonstrated on CT, the case should be discussed with the neurosurgical registrar on call, and that discussion and advice clearly documented in the patient's notes. As I mentioned earlier, in any patient with a head injury, it's important to consider injury to the cervical spine. And to do this, we need to decide whether further imaging of the cervical spine is required. There are several pieces of guidance which can assist the clinician in making this decision. The first piece of guidance is issued by NICE. The NICE guidance is summarised in this algorithm on this slide. So you need to be an adult presenting to the emergency department who sustained a head injury, and you need to assess whether any of the following risk factors are present. The first is that you have a GCS of less than 13, you've been intubated, a definitive diagnosis of cervical spine injury is required urgently, that other body areas are being scanned for injury or multi-region trauma, or that the patient is alert and stable but there's a suspicion of cervical spine injury and any of the following features are present: age over 65, a dangerous mechanism of injury, which is defined as being a fall from greater than a metre or fall down 5 stairs, an axial load to the head, a high-speed motor vehicle collision, a rollover motor accident, ejection from a motor vehicle, accident involving a motorised recreational vehicle, or a bicycle collision. If the patient has focal peripheral neurological deficit or paresthesia in the upper or lower limbs, then if the patient has any of those features, they should go on and have a CT of the cervical spine within an hour. If the patient doesn't have any of those risk factors, then there needs to be an assessment of the cervical spine. So if the patient's complaining of neck pain or tenderness, with any of the following low risk factors present that allow assessment of the range of movement of the neck. So the patient just needs one of these features. They need to have been involved in a simple rear end motor vehicle collision. They need to be comfortable in a sitting position in the emergency department. They need to have been ambulatory at any time since the injury. An absence of midline cervical tenderness, or presenting with a delayed onset of neck pain. If the patient has any one of those features, then they can have their range of rotation of their neck assessed. And if they can actively rotate their neck 45 degrees to the left and right, then they don't require any further imaging of their cervical spine. If they can't do that, they should have cervical spine X-rays performed within an hour, if those X-rays are normal, then the patient doesn't require any further investigation, but if they're abnormal, then the patient should go on and have a CT of their cervical spine. The second piece of guidance for us to be aware of are the Nexus criteria that have been around a long time and have been validated for assessing patients with adults with cervical spine injury. They're much simpler to remember, but one of the problems is that if you just use Nexus criteria, you end up imaging significantly more patients than if you rely on the NICE guidance or the Canadian C-spine rule. So the Nexus criteria: if you haven't got a focal neurological deficit, you've got no midline spinal tenderness, you haven't got an altered level of consciousness, you're not intoxicated, and you don't have a distracting injury, then the patient does not need to have further imaging of their cervical spine. The third piece of guidance just to look at, which is really what has been incorporated into the NICE guidance, is the Canadian C-spine rule. This has also been validated, and you can use either Nexus or the Canadian C-spine rule interchangeably. If you can clear a patient's neck using Nexus, you don't need to go on and then assess with the Canadian C-spine rule or vice versa. If you can clear the patient's neck with one of the rules, then that's okay. The Canadian C-spine rule, it just takes a little bit of looking at to get your head around it, because it's a bit more complicated, but good application of the C-spine rule means that we can make good quality decisions about which patients need imaging of their cervical spines. So the first question to ask, are any high risk factors present which mean that we need to immediately image the patient's cervical spine? And those high risk factors are age over 65, a dangerous mechanism, or paresthesia in the extremities. If the patient doesn't have any of those features, then it's the low risk factors which allow assessment of the range of motion again, which is it a simple rear end motor vehicle collision, sitting in the ED, ambulatory at any time since the injury, delayed onset of neck pain, and absence of midline C-spine tenderness. If the answer to all of those questions is no, then they need to have imaging. If the answer to any of those questions is yes, then you can assess the range of active rotation, and if that's 45 degrees to the left and right, they don't require any further imaging. If they can't move 45 degrees to the left and right on active rotation, then they need to have further imaging. You can see the box at the bottom right hand side that they define dangerous mechanism and a further definition of simple rear end motor vehicle collision. It's important to note that this rule is not applicable if the pain is not traumatic in origin, if the GCS is less than 15, there are unstable vital signs, the patient's under 16 years of age, there's acute paralysis, there's known vertebral disease, or if there's been a previous cervical spine injury. When discharging a head injured patient from the emergency department, it's important that they meet the following criteria. The patient should be alert and neurologically normal prior to discharge. They should be discharged with a responsible adult. They should receive both verbal and written head injury advice, which should be recorded clearly in the patient's notes. And they should be given clear safety net advice about under what circumstances they should return to the emergency department. These criteria are documented in the head injury advice leaflet in the emergency department, and you should familiarise yourself with these features in this advice. There are some special circumstances where you might need to modify your assessment, and these special circumstances include elderly patients, intoxicated patients, and patients who are anticoagulated. Elderly patients can be difficult to assess for head injury. Firstly, they may not complain of sustaining a head injury after a collapse or a fall. They may also suffer from a condition like dementia, which can make a full neurological assessment difficult. Elderly patients, because of age-related atrophy of the brain, can be at increased risk of subdural hemorrhage after head injury. For these reasons, it's important to be cautious in the assessment of head-injured elderly patients. The majority of coroner's inquests involving head injury involve elderly patients. Intoxicated patients can also be difficult to assess because the alcohol intoxication can cloud the neurological assessment. Intoxicated patients are often less cooperative as well. As a general rule, never assume that intoxicated head-injured patients' clinical condition is due to intoxication, as pathological head injury can mimic the features of intoxication. Lastly, we're just going to talk about anticoagulated patients. This slide summarises the guidance for the management of the anticoagulated patient. We use this guidance in any patient who is taking anticoagulants or any other antiplatelet medication except aspirin. The first part of the guidance pertains to whether the patient needs an immediate CT head scan. If they do not need an immediate CT head scan, then the patient should undergo a CT head scan 4 hours after they've sustained their head injury. If there are any high-risk factors present, which include significant mechanism of injury, extensive head wound or bruising, or an INR of greater than 3, or they live alone with poor social support, then the patient should be observed in the observation ward for 24 hours. Otherwise, the patient may be discharged home with head injury advice. If at any point an intracranial bleed is demonstrated on a CT scan in the anticoagulated patient, then reversal of the anticoagulant should be considered. Advice from the on-call haematology registrar should be sought for this. It is relatively common for patients to present to the emergency department sometime after a head injury with a range of symptoms that include tiredness, lethargy, headache, memory disturbance, and sleep disturbance. These symptoms can be quite disabling for some patients. Consider whether the patient meets criteria for a CT scan and give reassurance and advice that the symptoms are common after head injury and signpost back to their GP for follow-up care. I hope that this brief introduction to head injury assessment has been of some use to you. Please feel free to ask or mail me any questions that you have. As ever, senior advice is always available to assist you in making difficult or complex decisions.